Welcome back to OSCE Talk. Today we're going to be discussing MSK history, and then in the next episode we're going to go through more in detail osteo and rheum. So for this history, it's going to be really important to use your Socrates or your opera. If it's osteoarthritis, usually going to be a painful joint, and you'll use Socrates. Compared to rheumatoid, it'll probably start off maybe with a stiffness or pain. So again, you might use Socrates or you might use opera if it's stiffness. It's going to be really important in this history to be really detailed about which joints are affected. For example, if they come in with hand pain, you can't gloss over that. It's really important. Is it distal or proximal joints? For example, rheumatoid normally affects the proximal and rarely distal, and osteoarthritis in the hands is more commonly distal and rarely, and it can be proximal, but it's rarely the metacarpal phalangeal joints. So that's going to be the kind of detail that's really important to be specific about. Is it one joint or is it many? Someone might say pain in their thumb, but it could be both thumbs. Pain in their knee, but it could be both knees. For a joint pattern, is it the more proximal joints like the shoulders and hips, or is it more distal joints such as the hands or the toe joints, or is it weight-bearing joints such as knees and hips?
And then we need to think about some of the other associated symptoms. Very commonly, that'll be then stiffness, and stiffness is something that a lot of patients will present with the GP as well, because it'll actually impact on their ability to do things, especially in the morning time. So if you hear about stiffness, you need to think, is that actually morning stiffness that gets better throughout the day? You know, how long does it actually take for the stiffness to improve? Or is it stiffness towards the end of the day after use? Normally, stiffness that is present in the morning that then goes away after use is more likely to be a rheumatoid presentation or an inflammatory arthritis, whereas stiffness that sort of is present in the morning and then again comes back in the evening after use is more likely to be a degenerative cause like osteoarthritis. Then we need to think about the swelling. Is the swelling symmetrical? Is it, like Peter was talking about, the DIPs, the PIPs or the MCPs? Do they have other joints swollen like the knees? And again, if they're sort of asymmetric, a number of random joints involved, you're thinking about inflammatory. Then a lot of the inflammatory arthritis will have other systemic features, vasculitis features as well. That'll be basic things like fatigue, fever, weight loss, different rashes on the skins. There might actually be extra-articular signs. Very specifically, eye involvement. That could be things like anterior uveitis with rheumatoid arthritis. Mouth, are there aphthous ulcers associated with, Crohn's and other autoimmune diseases present? Do they have issues with the skin? Is there erythema nodosum present? Then we need to think about sort of red flags in MSK. Was there any trauma present? Is the pain extremely bad at night and actually waking them from sleep? You're always thinking about back pain, but specifically high back pain in the thoracic area. Thoracic back pain is a red flag in itself. And then specifically just to hone in on back pain, that's something that is completely a red flag and things that, again, are missed often in A&E and GP. Are you missing a Cauda Equina presentation? And the classic Cauda Equina presentation will be an extremely sore low back, but it doesn't have to be. Often they can have numbness down the backs of both legs or one leg, and then that can spread all the way to sort of the base of the foot, all the way around to the toe. With that, they might also feel numb sort of around the genital area or the saddle region, sort of where they're sitting on their seat, and that you could figure out using questions like, can you feel where you're sitting right now? Other things that might be present is erectile dysfunction, urinary incontinence, fecal incontinence, but also urinary retention as well. So often it can be quite non-specific, and it's just being able to sort of tease that out and making sure that you're not mistaking a Cauda Equina for a sciatica. One of the other things that's really important for patients with MSK problems is the mental health impact, and people with chronic pain often have significant mental health burden and aren't able to sort of carry out their activities of daily living. So then, as we're talking about, is there any diagnosis that they're currently living with that could be linked with their inflammatory arthritis? So that would be things like psoriasis, inflammatory bowel disease. Do they have problems with vasculitis? Those could all be linked. Typically older patients who've had fractures are more likely to be predisposed to osteoarthritis and degenerative arthritis. Is there any family history of autoimmune disease? And actually, what medications are they using at the moment? And for many patients, that could be a number of medications. That'll be basic things like, paracetamol regularly, ibuprofen regularly. Are they using topical gels on their hands or on their knees? Are they actually on stronger medications like opioids? Are they taking things like neuropathic pain agents? Or are they on disease-modifying anti-rheumatic drugs? So Basically, our OSCE Talk tip for this would just be to start with SOCRATES, identify the joint, get in those systemic symptoms. And I think very specifically, if you're asking about eyes, difficulties with passing urine, fever, weight loss, and then specifically asking back pain, I think you're going to be catching up a lot of the marks.
So just a quick summary, starting with SOCRATES or opera and identifying the joint pattern is going to be really important. Then ask your systemic questions on functional impact. Don't forget social, past medical history and family history. Really important. There can be a big genetic component with this. My 2 OSCE top tips would be to, as Matthew said, don't forget about red flag symptoms. It's really important. And also never dismiss these patients. They can be reattenders, but it's always important to be on guard and just make sure that that's always in the back of your mind. And secondly, it can be common when, depending on your university, but we can have real patients, and if you see these patients, they can be waiting on waiting lists for joint replacements for 5 or 6 years. So it's really important just to be really sympathetic about that, to get, just to build patient rapport and just ask about their mental health.
Yeah, and patients can be very frustrated with it. Often they've been waiting a number of years. They might actually be more disabled than they were to start with. They might be finding things difficult at home. They might be using a number of medications, specifically pain, chronic pain, and it's very complicated then to manage. Maybe they're seeing GP about, pain quite regularly. And then they might also now have to use things like walking aids. So these patients can be quite frustrated, really understandably. And it's just, as Peter said, really important to be extremely understanding.
Yeah, okay. So I think we'll just go into a bit of an MSK history now. Because we're doing osteo and rheum teaching in the next episode, I think we should focus more on a sort of red flag or Cauda Equina type picture. So just to recap what that is, that's normally a person who's maybe had a bit of trauma to the back, or it could be a cancer or infection like an abscess, and that's something that's pressing on the spinal cord, which will normally cause bilateral pain or numbness. Really commonly, as Matthew was saying, a numbness around the back passage. Other symptoms that you're going to be looking for is extreme pain. Patients who wake up actually from sleep from pain is a red flag. Weight loss, night sweats, fevers and rigors.
Yeah, and when you see these patients present to A&E or GP, it can be hard to distinguish that from other conditions like sciatica or just extreme sort of neuropathic pain. These patients could be quite difficult to examine as well because of the amount of pain they're in, or they may just have significant numbness. So obviously, because this is a lower motor neuron condition, as it's affecting the lower motor neurons coming back out of the back, we need to think about what signs will be seen. So they should have muscle weakness in the lower limbs, and that could be attributed specifically to nerve roots, whether that's sort of L4, L5 or below. They may have reduced or absent reflexes, so it's important to test the ankle jerk, the knee jerk. They'll have low tone in the legs, and that means they'll feel more floppy and flaccid. And then, as I said, they'll have significant sort of numbness and tingling, and that can go from the saddle all the way down to the backs of the heels and round. And then just being aware that it can be both bladder and bowel incontinence and dysfunction. However, some patients also have urinary retention, and they may present purely with a urinary retention to A&E. Other examinations that you might do, just when you see these patients, you may do a PR exam to check for reduced anal tone. And then the gold standard imaging would be an MRI of the spine. This patient might need surgery to decompress the nerves in their back, and that'll normally be done by the neurosurgeons or the orthopedic surgeons, depending on the unit.
Yeah, so this history is going to be a patient in A&E, sort of with an acute onset of back pain. But just to mention, again, these people can actually have back pain ongoing for a little while and might have seen multiple doctors. So it's just important to take these people at face value. It is possible that you're missing a diagnosis, so always have this in the back of your mind, and it's not something you want to miss. Okay, so we'll just move into history.
So hello, my name is Matthew. I'm one of the resident doctors in A&E today. Do you mind if I check your name and age, please?
Yeah, my name is Peter, and I'm a 52-year-old man.
Okay, Peter, can I ask why you've come into A&E today?
I've just been having really, really bad back pain.
Okay, and tell me where that back pain is, Peter.
It's just right down here in my lower back.
And have you ever had back pain like this before?
On and off, but this is really bad.
And when did this new pain start?
2 days ago.
And over the last 2 days, has that changed at all?
It's just getting worse, and I'm starting to feel a bit numb as well, sort of around the lower back.
And any words that you use to describe the pain?
Just like a dull ache, and it's there all the time.
And just for the last 2 or 3 days then?
Yeah.
And does that pain move anywhere? Down the backs of the legs, up further up the back?
More down the back, both legs.
And has this been going on constantly now for the last 2 days?
Yeah.
Is there anything you can think that, would make it any better, any worse?
Can't get any relief at all. sore my eye down. It's definitely worse when I get up and try to walk. And to be honest, I'm struggling to walk at the moment.
You're struggling to walk at the moment. And are you normally fit and able to walk about the house?
Yeah, I work as a builder.
Okay, so you're very fit and active. Are you able to walk at the moment?
I'm struggling.
And if you had to rate this pain, 10 being the worst pain you've ever felt, what would it be at the moment?
I'd say it's a 9.
Right, Peter, I'm quite worried about this pain at the moment. I think I'd like to start you on some pain relief, and then we can sort of have a bit more of a chat about some of these symptoms. You mentioned a bit of numbness as well.
Yeah, both legs, both down the backs of both my legs, feeling numb. Yeah.
And have you ever had numbness or tingling like that before down the backs of the legs?
Never.
Is there numbness anywhere else, such as, around the genitals or anything like that?
Now that you mention it, yeah, around my back passage is actually a bit numb.
How long's that been going on for?
I just noticed this morning when I was going to the bathroom.
And could you feel yourself going to the bathroom, or was there any difficulties with that?
It felt a bit strange.
And were you able to feel sort of yourself wiping or anything?
It just felt really weird.
Peter, have you had any difficulties passing pee today?
No.
Just some other questions I want to cover as well, Peter. Have you had any sort of temperatures at all recently?
No.
Any problems with sort of sweating at night?
No.
Or waking up at night with pain in the back?
This has woke me up last night and I couldn't actually get to sleep, and then I woke up and again with pain.
And have you had any change in the weight at all recently, Peter?
Yeah, probably over the last 3 months I've been losing a bit of weight slowly.
And was that on purpose or just accidental?
It was accidental. I'm not trying to lose weight.
And just to check, Peter, have you had any injuries recently?
No.
And do you have any history of any conditions at all, Peter, at the moment?
No.
Have to ask this, any history of any cancers or anything like that yourself?
No.
And any history of any problems with the back?
No.
Any surgery to the back ever in the past?
No.
Any history of any slipped discs or anything in the back?
No.
And I'm sorry I have to ask this, Peter, any history of any cancers or anything yourself?
No.
Anything that would run the family at all?
Not really, I don't think so.
Specifically, any history of problems with the back?
No.
Do you take any regular medications at the moment?
No, but I was taking some Cauda for this.
Okay, and can I ask how strong those Cauda were?
It was 8/500s.
And how many have you taken of those?
I was taking the max like 2-4 times a day.
Have you found that you're getting any relief from that?
No, very little.
Any other medications that you're on at the moment, Peter?
No.
Any allergies to any medications?
No.
And how's this all impacting you at home? Over the last few days, are you able to do sort of your normal? You were mentioning difficulties with the walking.
Yeah, well, I've just been off work, and then it's sort of been, it got quite worse very quickly, to the point now that I just feel like my legs wouldn't support me if I try to stand up.
I'm sure that's really worrying for you, Peter, and look, we're taking this really seriously at the minute.
Yeah, thanks. I'm very worried.
Peter, have you ever needed help at home or anything else like that?
No.
And do you live by yourself alone or anything at the moment?
I live with my wife.
Do you smoke at all at the minute?
Yeah, I've smoked, yeah. I've smoked 20 a day for the last 40 years.
And would you drink any alcohol?
Not really.
Any questions or concerns that you have for me at the moment, Peter?
I'm really worried about this back pain. I want to get an answer.
Look, I'm quite worried about this. I think I want to have a look at the back, but we also might want to perform some tests, and I'm happy to answer any of the questions from the examiner at this stage.
Okay. Yeah, thanks, Matthew. So next episode is going to be on sort of osteoarthritis versus rheumatoid arthritis.